would say before starting this talk, don't shoot the messenger. These slides have been prepared by Dr. Haris. There isn't, I think, too much complex cardiac stuff in this, as I'm a vascular surgeon, not a cardiac surgeon. But I've got Dr. Khalid Rashid, the cardiac surgeon, sitting here, so he can help me out if there is any need. Right, okay, so you can see here, there are 4 pictures of some famous people. And what's common in the slide of these 4 people is that they all died of aortic dissection. So you can see there are some famous people who were diagnosed as having aortic dissection. And then this slide basically shows some young people on which there was quite an inquiry and a case in America, because they again had aortic dissection with which they presented to A&Es in America, and they were misdiagnosed, and the end result was not very fortunate. So big inquiry was done, and the awareness, basically, it was basically to raise awareness of aortic dissection. So type A dissection, this is how it looks like. Not a very nice picture to see when you open a chest. And as I said in my talk, unfortunately, this disease is associated with quite a high mortality, both non-intervention and intervention cases. So reduction in mortality is linked to volume of procedures. It reduces stroke rate and associated morbidity, and decreases ITU and hospital stay. So this is when you've done a repair, this is how it looks like. As you can see, it is quite a complex procedure. It's not just one graft which needs to be done, and that's the end of it. It is basically multiple grafts, because, and especially if there is involvement of root, then basically what is required is to do the root replacement, valve surgery, then reperfuse the coronaries. At the moment, the procedure that Dr. Haris is doing, I just was there about 10 minutes ago, and he had done the root. He was reperfusing the right coronary, left coronary needed to be done. He had taken, the patient also, because of calcified vessels, also needs cabbage. So essentially, he's already put in the vein grafts on the coronary arteries, and they will need to be reperfused. And then the graft will need to be attached to the main aorta below the innominate. So quite a complex procedure with multiple anastomosis and reperfusion of multiple vessels. So incidence of aortic dissection is up to 50 per million population. A number of cases are not recognized due to lack of awareness and diagnosis. Mortality, as I've said, is high when left untreated. 33% of patients die within the first 24 hours, 50% within 48 hours, and 75% within 2 weeks. So that's why this is a killer disease. Operative mortality, unfortunately, is not low as well. It is quite high. But if you compare it with the patient who's come in with a type A dissection, who's almost certain to die in a very short time, then this 20 to 25% is an acceptable mortality. And there is improved mortality and outcomes in hands of experienced aortic surgeons. What are the benefits of patients? For patients, prompt diagnosis and transfer for surgery if the service is there. Reduce time and earlier intervention, reduce morbidity and mortality. This is essentially what we're talking about, is to develop a service in which these dissections are identified immediately, and a decision is made to go for early intervention. There is a need for collaboration between different centers for this, and a collaboration between the different departments of the same center. This is a hybrid device, which is quite a new device, and it is used for very complex, for these complex procedure, and it gives an option of open repair and dealing with a difficult or ongoing type B dissection at a later stage as well. So type A dissection can present in different ways, involving only the ascending aorta, going into the coronaries, involving the arch, or going into the thoracic aorta as well. And this is a picture of a post-op patient who had replacement done of his root and arch, and then thoracic graft done for the type B segment. These are the different mortality figures quoted by different centers. In IRAD registry, it's 26%, SCTS, it's 22.8%, and Liverpool is a large center for open complex aortic surgery, thoracoabdominal aortic surgery, and there it is 10%, and that's where Dr. Harris has trained as well. Volume outcome relationship, this is something which is very big in aortic and vascular surgery, I'm sure in cardiac surgery as well. It has been clearly shown over the last 1 to 1.5 decades that the centers where the volume is high, the outcomes are better. And the centers where the volume is low, the outcomes are worse. And therefore, in majority of the world, complex vascular and cardiac surgery has been centralized in order to improve outcomes. This again shows the same, higher the volume, the better the outcome. Acute type B dissection, I've discussed it in my talk as well. Basically, you can have dissection involving different segments, presenting as an aneurysmal dilatation, presenting as intramural hematoma, and everything needs to be taken on board, and then a best decision made for the patient to manage it. Okay, so this is again a picture showing type B dissection. So a little bit about thoracoabdominal aortic aneurysms. Let me just check if there is, have they reached the theater yet?
Assalamu alaikum ji.
Yeah.
Lovely. So we've got a 51-year-old male who had a renal transplant in 2012. Following that, he ended up with a delayed rejection, and he's got CKD for which he's under surveillance. One of my, the table slightly away from me, Ji. One of my colleagues, he presented 3 days ago with chest pain, feeling unwell, a bit of back pain. The CT was done because on the second day of his admission, he ended up with an acute ischemic stroke and slurring of speech and weakness of the right side. CT scan was done, which showed a type A dissection, which was originating from the left, from the non-coronary sinus, that's where the tear was, and extending into the ascending aorta, going further down up to the arch, and most probably involving the left common carotid artery. On further investigation, his echo showed an ejection fraction of 30%, and the CT also showed extensive coronary calcification with significant triple vessel coronary artery disease. He also had severe aortic regurgitation. Severe aortic regurgitation, dilated left ventricle, torrential AR with complete lack of coaptation of all his leaflets. So our initial plan was to go in through an axillary cannulation and cool down while we can then do an open distal anastomosis and probably replace the hemiarch. Considering his poor left ventricle, prolonged surgical time, we opened up his chest where we found the tear which was originating in the left coronary sinus, and we ended up replacing the aortic root with a tissue prosthesis, replace the ascending aorta, and I'll show you exactly where we are under the hemiarch. In addition, to avoid having an intraoperative or post-op ischemic event, we ended up doing bypass grafts on all his coronary arteries. That involves the right coronary artery, the PDA, the LAD, and the circumflex artery. So I'm just about finishing my last proximal anastomosis on the new ascending aortic graft, please, new aortic graft, and that should take another 4 or 5 minutes, and then I shall be able to show you the extent of dissection and replacement of aorta. Ideally, in a 51-year-old gentleman, what we aim to do will be a valve-sparing aortic root replacement plus ascending aorta, and replace the arch with something called a Thoraflex, which is a hybrid frozen elephant trunk. And we have extensive experience of doing that. We did the 500 frozen elephant trunk last year, and that involves replacing most of the arch. And it also gives us the luxury of having a landing zone in younger patients for future deployment of stent grafts. If not, it also gives us the possibility of having open surgical repair, where we've got frozen elephant trunk that can be anastomosed to the new abdominal aorta, descending thoracic or abdominal aortic graft. That is pretty much it in terms of type A dissections. Here in Shifa, we provide a 24/7, 365 type A dissection repair service, and the results are pretty good. This guy was quoted a mortality of around 50 to 60%. He was also quoted a mortality of a stroke risk of around 25%. And he was told very clearly that most probably because of his CKD4, he will end up on permanent dialysis. And within the next few days, he would require hemofiltration. He's a young guy, and the family wanted to give him a chance. So that's where we are. Do you have any questions, sir?
Yeah, Haris, can you hear us?
I can.
Okay, Haris, Khalid Rashid here. I just was telling the same thing, that generally in acute type A dissections, one tends to do the minimum optimum possible thing, and as you have just confirmed this as well, that although you initially planned to do a hemi-arch, you are not doing a hemi-arch.
Yeah, I think the most important thing with these patients is their age, their comorbidities, and pre-existing coronary artery disease. I think, as any cardiac surgeon would tell you, is the most important thing is to get these patients out alive, rather than doing the optimal operation. But in a 51-year-old guy who had no comorbidities, I don't think so even a hemi-arch is an appropriate operation. And if you've got genomic Marfan / Ehlers-Danlos loss or any other connective tissue disorders in an aortic center, I think that's where the thing comes. If you do dissections day in, day out, and you do aortic surgery day in, day out, you can be a bit more kind of liberal with what you're going to do. Just very quickly, let me start running. I'm just going to DA the heart, so if you just give me a couple of minutes. Okay, do you fill the heart? You would boss. Gently fill the heart. Can I have a few big blows on the lungs, please?
20-25% stroke incidence. That also would come drastically down the incidence by not doing a total hypothalamic circulatory arrest. And by only doing the SPA, right? You are not stopping the pump.
Stop on the rearranging.
The incidence of stroke will not go down.
Okay, could you stop there? Empty the lungs. Stop the lungs. Run the hot shot now, G. Hot shot. The genes go disconnected. We should be on retro. Retro hot shot, please. So what we've done here, if you could bring the camera down, I can just show. I've got 5 minutes. Run the hot shot, run us up.
Sorry, Haris, can you just move the theater light slightly so we can see?
Just move the theater lights. Don't see anything.
थोड़े से कैमरे को पूरा ऊपर टिल्ट करें, थोड़ा सा नीचे और नीचे, थोड़ा सा और नीचे करो, नहीं इस तरह कर दो ना कैमरे को, that way, that's perfect. नजर आ रहा है जी
नजर आ रहा है, लेकिन ज़्यादा इतना क्लियर नहीं है because of light.
वो आपकी लाइट जो है ना, that makes it very bright and
आपकी लाइट के बगैर बेहतर है.
Light now it's better.
So what we've got is what you can see is that's pretty much the size 26 Mackay graft, which has got a 23 millimeter Hancock valve inside. That's the coronary anastomosis that's going to the right coronary artery. That's the PDA on the back. That's the anastomosis that's going to the LAD. That anastomosis is going to the OM. So once, if you give me another 5 minutes or so, I'll take the cross clamp off and show you exactly how we prepare in terms of arch and if you're going to do a frozen elephant trunk or a total arch replacement. So just give me a couple of minutes. How much hot shots in?
Okay, Haris, I think what we'll do is I'll do the quick presentation on thoracoabdominal, which you've given me. And then we'll come back to you in about 7 minutes.
We should be ready in 15-20 minutes. Yep.
Okay. We'll have a short talk on thoracoabdominal aortic aneurysm, and then we'll go back to theater and see what's going on there. So this is a CT picture of a patient with a large thoracoabdominal aortic aneurysm, as you can see, extending all the way down into the abdominal aorta around the visceral vessels. So the incidence is about 2.2 per 100,000. It's more in females than in males. Causes for thoracoabdominal aortic aneurysm: degenerative, aortic dissection leading on to formation of aneurysmal aorta, connective tissue disorders like Marfan's, and familial causes. Risk factors for these patients: hypertension, increasing age, smoking is a massive risk factor. Bicuspid or unicuspid aortic valves leads to development of aneurysmal aorta over a period of time, atherosclerosis, COPD, renal failure, and previous aortic aneurysm surgery. 5-year survival, 7 to 20% if not operated. So quite low survival for patients who are not operated. And the size at which generally we go on to perform the surgery is about 5.5 to 6 centimeters. Risk factors for rupture: increasing diameter and growth rate, similar to what we see in the infrarenal abdominal aortic aneurysms as well. COPD and continued smoking causes the aneurysms to grow quickly and therefore higher risk of rupture. Increasing age, presence of symptoms, for example, pain, or inadequately treated hypertension, renal failure. Marfan syndrome is an entirely different category, which is associated with its own problems as well. So extent of thoracoabdominal aneurysms, they extent 1 to 5, depending on the area of the thoracic and abdominal abdominal aortic involvement, and the complexity of the surgery changes with all these. So this is a picture showing replacement of a thoracoabdominal segment with reperfusion of the visceral vessels from the grafts, smaller grafts taken from the bigger graft. Things have moved on to endovascular or hybrid approach as well. So this is, you can see a picture of a thoracoabdominal aneurysm with a branched aortic stent graft. These are branched grafts and fenestrated grafts are for complex aortic disease in which there is option to keep the branches, the important branches like visceral, SMA, celiac, renals, getting perfused as well. The fenestrated grafts are custom made as per the anatomy of a patient. The branch devices are on-the-shelf devices with slightly different configurations, and they can be used as required. The question basically is, which is the better option, open or endovascular? And it's the same debate as we have seen the debate in open versus endovascular for abdominal aortic aneurysm. And the general consensus at the time is that younger, more fit patients, maybe open repair is a better option because of its longevity. MDT approach is extremely important for these patients, as you know that these things cannot be done by a single person. So MDT based management is to tailor the management to individual patients, explore all the available options and identify which is the best option for a particular patient based on their fitness and based on the anatomy, and utilize expertise from all specialities. Decision making is to be done between the MDT, involving the patient, involving the family. Adequate information needs to be given, and the team also needs to understand their skills and their limitations. The decision for treatment depends on pathology, extent and size of aneurysm, general fitness of individual patient, suitability and availability of treatment, availability of the specialist skills, and obviously its availability of funding, not just in our country, everywhere else, because these are all very expensive procedures. Imaging, CT scan is the imaging of choice. It gives us quite detailed information, not only about the disease segment of the aorta, but also about the branches, and it helps us in planning, as explained in detail by Dr. Jumshed in his talk. Fitness assessment is extremely important. Patients need to undergo proper fitness assessment, include for their lungs and for their heart, and obviously kidneys and the rest of the organs as well. These surgeries essentially put a lot of stress on the patients, and this stress does not necessarily come out during the procedure, but also during the couple of weeks up to about a few months after the procedure. So just making through the operation theater into the ICU does not mean that the patient is out of danger. It is a complete recovery that is to be looked at. So essentially, good cardiac and pulmonary investigations are extremely important.
Thank you very much, Dr. Umar, for the privilege of being here. My name is Dr. Bilal. I'm one of the consultant cardiac and aortovascular surgeons at Shifa. I've been working at Manchester Royal Infirmary as a consultant cardiac and aortovascular surgeon for the last 6 years, and before that another 15 years in Manchester. This is what we published late in 2019, and I was one of the authors. We in Manchester perform more than 120 type A dissection repairs with a frozen elephant trunk. In summary, what a frozen elephant trunk does is that all the young patients that we have, rather than just replacing, just putting an interposition graft and not replacing the root or the arch itself, and not leaving any landing zones for future intervention in younger patients, because most of these patients are actually genetic connective tissue disorders. They're either Marfan's, Ehlers-Danlos, bicuspid aortopathy, and all these genomic patients, if we follow them up properly, they will present with further issues further downstream or proximally within the root itself. So one of the best operations and state of the art, what we do is replace the arch with something called a Thoraflex hybrid device. I've had extensive experience with Thoraflex hybrid device over the last few years. I'm a proctor for Vascutech. We did the first, this is how it works. This is what a heart would look like and how you will get an aneurysmal formation. As you can, I'm sure all of you can appreciate the anatomy. So this Thoraflex can be used in isolated aneurysms. It can be used in type A dissections. It can be used in chronic type A's, chronic type B's, and pretty much everything. And as you can see, they're just showing a description of how the arch becomes aneurysmal in the proximal descending thoracic aorta. So during surgery, what you do is you put the patient on bypass, cool them down, do a circulatory arrest, and then put a guide wire through the femoral arteries. And this novel Thoraflex device, which has got a stent mounted at the end, and it's malleable tip. It can move, it can bend. You can use it whichever way, and it doesn't damage the stent graft itself. You can use a guide wire, especially if you've got a type A dissection. You stick in the true lumen. In chronic type B's or type A's, you can also use a guide wire. And what you do is you just deploy the stent graft distally in the descending thoracic aorta. And they come in various sizes in terms of length and in terms of diameter. They start from a 26 millimeter, they go all the way up to 34.
And the length of the stent graft comes into 150 and 100 centimeters, 10 or 15 centimeters. And then you just simply release the device. It's got a beautiful collar at the end, which you can see around here, which you can use for your anastomosis. And we simply use the 3-O-proline and a few pledged stitches to do that. And then you replace the 3 head and neck vessels with the innominate left common and left subclavian. Most of the times in type A dissections, what I do is I normally tie off the left subclavian from the inside and do an extra anatomic bypass. This is what we did. I'll just present the data that we have.
Many people, as they get older, may notice changes in memory and thinking ability.
Sorry. Just let me quickly bring it down. I'm just presenting what we did. So this was between 2013 and 17. This is the data from all the UK who've had a frozen elephant trunk and total arch replacement in type A dissection. And the results are pretty good. The 30-day mortality is less than 15%, which is very acceptable in type A dissections. The international IRAD data, you'd realize overall across the globe, the mortality is over 25 to 30%. In my experience, for the last 120 type A dissections I've done, the mortality is around 4.5%, so it's not bad. The risk of stroke with all these procedures is around 5, that's what I'd quote the patient, 5 to 10% risk of stroke. But normally you can get away with 5 to 7% very easily in terms of risk of stroke. The one thing that all these patients end up having, and I always consent them for, is renal dysfunction. In my experience, the incidence is way more than what's reported in the literature, and you're looking at anywhere around 35 to 40%. So 1 in 2 of these patients will end up in some form of renal replacement therapy, but it's not permanent, and they recover really well. So that is pretty much it. This is something we are doing in Shifa. We are providing, we've got frozen elephant trunks available. We have all the grafts and we have a service. We've done a few cases jointly. A couple of weeks back, we've done a descending thoracic aorta, and subsequently we'll be hopefully extending it to all our EVAR and TVAR services, all these type A dissection patients. So we've followed closely and subsequently have TVARs and completion surgeries further downstream. Do you have any questions? So in terms of coronaries, most of these patients, so it's quite variable. Normally the coronary sinuses are spared in type A dissections. Like in my experience, 70% of these patients have tear extending from the non-coronary sinus. But in case you have problem with the coronaries, or these patients present with an acute MI, what I tend to do is I tend to do the bypasses, the coronary artery bypass drafting as the first thing before I touch the aorta. That's what I did today. So I didn't touch the aorta, I didn't open it up. I did bypass grafts on all 3 coronary arteries, which you can see. I'm not sure if you were able to see. And you do the bypasses. I'll see if I can get a quick snapshot when I go down. You do all 3 coronary artery bypass draftings because you can't do a coronary angiogram because these patients are really sick. So what you tend to do is, if you've got ischemic changes in the right territory or inferior territory, you just graft the right coronary artery. If you've got changes in the anterior leads, you just end up grafting the LAD. And if you're not sure about the coronary anatomy, most of the times I'll graft all 3 coronary arteries even before I start the operation, which is replacing the aorta. And what we do is protect the heart through those coronary arteries throughout the 6, 7, 8, 9 hours to make sure that the myocardium gets enough cardioplegia and it stays still. And at the end, once you've done your aortic anastomosis and everything, you can attach the bypass graft to the new graft. It's quite simple to do. It just takes an extra hour and a half, 2 hours of your operating time, but it's quite simple. In case you don't want to do bypass grafts and you've got tears within the coronary ostia, you do something called a Cabral procedure, which involves taking an 8mm graft and you dissect the right coronary artery a bit further and you connect that 8mm graft straight to the aortic graft. That's called a Cabral. And what you can do, a modified cabrol is where you take a 10 millimeter graft, attach it to the ascending aorta, and take it all the way back into the left main stem. That's the other thing you can do. But most of the times when I've had to do a cabrol, it's been in redo situations where patients had some previous surgery, like a mitral valve replacement, an AVR, or a previous CABG, and the tissues are so stuck that you cannot mobilize the coronary ostia. To avoid mobilizing and causing damage to the coronary ostia, what you do is you do a cabrol, and that works really well. And the benefit of doing a cabrol and having an 8 to 10 millimeter graft is you can look up and down. Even if it's bleeding, it's quite easy to control as compared to direct implantation of coronary ostia, which I did today. Thank you very much. Thank you. Jack.